Next is Dr. Donovan. Heidi Donovan is a professor in the Department of Health and Community Systems at the University of Pittsburgh School of Nursing. She's the director of the McGee Family Care Center at the University of Pittsburgh Medical Center, which provides support and leads research for patients and caregivers impacted by gynecological cancers, if you would.
All right, I just have to say, wow, Mandy, that was a hard act to follow. I could do my presentation quickly by just saying what she said. But actually, I think it's a good way to maybe frame what I'm going to talk about next. So I come from a pretty long history of doing research in symptom management, symptom self-management. And through the course of those studies, some with patients, some with caregivers, I've constantly been struck by the work that's required to do symptom management, work on the part of patients and their family members. I also went back and had a sleepless night and thinking about what we had heard yesterday and what was missing. We all bring these different lenses to this problem. And my lens is this lens of work. And I think, so what I'd like to rename my talk is Team-Based Approaches to Support the Work of Self-Management in Oncology. So I'd like, some of my talk is sort of back to the future. So I would like to talk about the chronic care model. So this is a model that's been around for ages, but what it really talks about is it's that it takes a village to get people to better functional and clinical outcomes. It takes the community, it takes really well-developed resources that we heard about yesterday, it takes policy changes, it takes really good health systems, organizations of healthcare. That include self-management support, delivery system design, decision support, clinical information systems that actually work, that are interoperable, that actually are designed to support the clinicians in the hard work that they do and the patients in their record-keeping, not designed purely for billing. What I want to talk about is self-management support done by a prepared, proactive practice team. And in order to have really good interactions to create informed, activated patient teams that can lead to good functional and clinical outcomes. So provider teams, I think we heard yesterday a lot about physicians, and I am one of the biggest physician advocates that there are. Physicians are some of the hardest working providers that I have seen and I could ever imagine working with, but they can't do this on their own and they shouldn't be doing all of this. So a provider team really means other providers in the system, nurses, social workers. We can call them navigators, nurse navigators, lay navigators, social work navigators, physical therapists, occupational therapists, rehab therapists. These are all people that have to come together to improve patient outcomes in oncology. What do I mean by the patient team? And I think this was really missing for me yesterday. So the patient team is certainly the patients that are dealing with the cancer diagnosis, but it's not just the patient, right? It's their closest support person. So it may be their husband, their wife, their spouse, their partner. It could be their closest friend. It could be their daughters, their sons. It could be their parents. It could be the whole extended family, their trusted neighbors, colleagues, and friends. This is the patient team, and we can't leave them out of this picture. So part of this is just to recognize that we have to start valuing the invaluable, and this is directly lifted from AARP's 2015 policy update. Also, others have highlighted, and I'm going to focus on the cancer survivors, but we currently have 15.6 million cancer survivors. We have a silver tsunami coming of a whole bunch of older caregivers or older patients and caregivers. The estimates are that there are 4.6 million family caregivers, and that's a really conservative estimate. Really, it's probably like 3 times the number of patients, right? But this is the family caregivers who are actually providing care to a loved one that has some kind of activity limitation. So they're critical. And as we all know, we're asking them to provide higher and higher levels of care at home. We're asking them to do things that used to be done in the hospital or in the outpatient setting. And they're not prepared to do that. So I want to talk about self-management. What is it that we're asking people to do to manage their own lives with cancer? So self-management could be sort of broadly defined as the tasks of illness-related work for patients and families with cancer. Others have defined it in cancer as the awareness and active participation by the person and their family in their recovery, recuperation, and rehabilitation to minimize the consequences of treatment, promote survival, health, and well-being. So self-management is hard work. Like I said in our studies, the people who need it the most are the sickest, and it's hardest for them to do, right? So it's hard work, and we have to understand it in the context, meaning the culture, the setting, and the individual family and community resources of everyday life. And this takes us back to Corbin and Strauss, who did a seminal study on the domains of illness-related work. And they characterized that illness-related work in terms of the actual illness-related work, the biographical work that has to be done by patients and families, and the everyday life work that people have to do. And I'm going to argue that symptom self-management is a key feature of many different areas of this illness-related work in oncology. Howell and Klimek have both talked about the 9 domains and tasks of illness-related work in oncology, and I'd like to share some examples with you. So illness-related work has several components. So patients and their family members have to manage disease and treatment regimens, right? They have to understand their disease. They have to understand their treatment. Often they have to participate in managing that treatment. They have to understand the regimens. They have to manage devices and other assistive technologies. They have to actually, in managing disease and treatment regimens, I actually also want to go back and talk about transitions, right? There are a lot of transitions they have to deal with. They may have to transition back to primary care providers, and right now we make them hold that information and share that information. They might have to go to palliative care. They might have to go to long-term care facilities. So there's a lot that has to be done in that context. They have to manage multiple and interacting symptoms. So we have to ask them to monitor for these different symptoms and toxicities. When do they need to react to them? What do they need to do to manage them? When do they need to call their providers? What are the side effects that they need to know about? How do they manage the side effects and adherence to these treatment recommendations that we're asking? How do they communicate those symptoms effectively to their care providers? How do they manage those interacting things? The more symptoms, the more side effects, and where is it coming from? They have to manage all of that. Oh, I already told you about navigating and negotiating transition. So another big piece. So that's the illness-related work, and that's just sort of skimming the top, right? Then they have to combine that with what we call the biographical work of having cancer. So contextualizing cancer within life. So how do people fit cancer into their day-to-day life? How do they accommodate what they have to do in the context of cancer? How do they adjust to those things that they can't do anymore? They have to come to terms with a new normal. They have new limitations. How are they going to do that? They've changed their whole life perspective. It's affected their family. They're trying to protect their family. They need to reconstitute their identity. Some of it's physical, it's emotional, it's psychological. Who are they? What were they before cancer? What are they after cancer? They have to recast their biography. They have to let go of certain things that they had thought they would do. They have to grieve with that loss. And they have to envision a new future. So that's a huge piece, right? What are my life goals now that it's been limited in this way? Finally, we have to take that illness-related work, the biographical work, and the everyday, and then combine that with the everyday work, right? And everyday work could be thought about as relationship work. Relationships are really important to us, everybody, right? It's part of who we are. And how do we negotiate and reconnect with people? How do we maintain relationships with those closest people? How do we maintain sexual intimacy in the face of illness? That's tough work. There's occupational work for the family and the patient. Are they taking time off work? Can they take time off work? Can they get supported from their work to continue the work of cancer? Who's going to do that work? What about discrimination in the workplace? What about loss of wages? How do we balance all that? These are just overwhelming things. And then they have the emotional and the psychological work. They're facing their mortality. There's sadness, there's anger. How do they protect and communicate with their families? How do they protect their families from that work? How do they learn the coping skills to manage the chronic stress of a life-threatening illness? There's health maintenance work. These people don't come to cancer with just cancer. They have other chronic diseases that they have to manage in the context of cancer, and they have to think about health behaviors to limit the late effects of cancer treatment. It's not just something that comes 10 years down the line. It's something that they need to be working and preventing along the way. And finally, there's housekeeping work, right? All of us have to manage our houses. Life goes on, right? We have to keep doing those things that run our household. So how do we do that? And how do we adjust those things if we have limitations after cancer? So that's the work of that's the work of self-management in cancer. And I don't think we talked about that enough yesterday. So my question and my argument is that supporting patients and families in the very complex tasks of monitoring, communicating, and managing the disease and the disease and treatment-related symptoms in this complex system is essential for quality cancer care. So, and the big argument with that is self-management is not a knowledge-based skill. It's not solved with information. Self-management is a behavior. It requires ongoing behavior change support from a proactive, interdisciplinary healthcare team supported by systems, resources, and policies that value and reward this challenging work. I lifted some of that from Doris Howell, but I think it was in there before, and I'm sure it's been in all of your heads, but I love the way she phrased that. So what does that mean? I'm not going to read all this because I just told you what the work is, but we have to make it tailored to the individual. We have to coach in behaviors and skills over time by a trained educator. We have to increase patients and families' confidence to manage symptoms, illness, and care, set their expectations high. We have to teach support of self-monitoring and symptoms to adapt behaviors. It's not just monitoring. It's not just PRO, electronic PROs. Once you get that, you have to deal with it and you have to help people know how to understand it. We have to support development of skills for communicating with the care team. We have to support development of problem-solving skills and daily decision-making. We have to facilitate behavior change through goal setting and action plans. And we have to foster collaborative partnerships from our patients. Let them know they're part of the team. They are part of the partnership. And we have to encourage them to use the available support. So I lied. I read all of that because I think it's kind of important. So here are my recommendations. First of all, going back to the AARP, we have to value the invaluable, meaning the families and the patients who are doing this hard work at home. They provide greater than 90%, up to 99% of the care to our patients, right? And we do not value them. So there are 40 million family caregivers in the U.S. About 9% of those are caring for a patient with cancer. We know that those caregivers are providing higher levels of care than many other types of caregivers. So if you look at that, all of this, you could take out 9% to calculate it, but let's just talk about caregivers in general. So they're providing 37 billion hours of care per year. And if you use sort of an average across states for what it would cost to have an in-home medical assistant providing that care, the value of their unpaid care is about $470 billion per year. That's crazy, right? That's resources that ought to be funneled back into the system to support them. And if you look at how much $470 billion is, so the economic value of family caregiving is as big as the world's largest company. It's bigger than Medicaid and out-of-pocket spending on healthcare. It's huge. And these are caregivers who are untrained, unrecognized, and undervalued. So my recommendations developed at 5 o'clock this morning, are the oncology community should actively participate in policy initiatives to support families facing cancer. There are a lot of them. So you can look at AARP. I highly recommend looking at the National Academy Report on Families Caring for an Aging America. The Administration for Community Living is doing great work to gather resources for family caregivers. We don't have to recreate the wheel. This is out there. And a lot of this is trying to find financial compensation, really, in many different forms for the families and patients who are doing this work of caregiving. The other thing is we should assure caregiver preparation and support across the serious illness care trajectory. Several groups have come out and said that we need to identify, assess, and support family caregivers across the cancer trajectory. And we have to explicitly invite caregivers to serve as members of the care team. Just quickly share with you, we're trying to do this. We're trying to implement some of the work from my team's research over the past 15 years into clinical practice at the McGee Women's Hospital of UPMC. So we have a Gyn-Onc Family Care Center. Our goal is to identify every new patient's primary support person, gather basic information about them, which you see on the left-hand side, really share with them that we recognize what a difficult job we're asking them to do and that it's stressful and that they probably have a lot of unanswered questions. We do a simple NCCN distress thermometer with a problem list that's adapted to caregivers to try to understand what their unmet needs are, and then we intervene to do that. And we work very closely with our social work navigators. We work with behavioral medicine. We work with palliative care. And we work with the advanced practice providers and nurses in our clinic to do that. My next set of recommendations is that the oncology community should advocate for policies and systems that promote multidisciplinary care teams with each member working at the full capacity of their training and licensure. So that means physicians that have the time to do what they do best, right? Which is care for the patients, do surgeries, medication, do the most aggressive and evidence-based management of cancer that they possibly can. It's advanced practice providers practicing at full prescriptive and full licensure authority. It's social workers who are providing counseling and advocacy, not just support in transportation and parking. It's nurses, frontline nurses who are supported to do that symptom self-management coaching. It's occupational therapists and rehab specialists and physical therapists that are brought in to make sure that patients return to their previous level of functioning and participation in the community. It's behavioral medicine, it's palliative care. And I would, an example of this practicing at full capacity, look to some of the nursing organizations. There's also Robert Wood Johnson Foundation reports on the future of nursing. There's another one coming up, another council that will be working on the next wave. And then finally, identify and implement models of care and reimbursement that enable the healthcare team to provide self-management support across key transitions in the illness trajectory. And I think in that, we look to our chronic care, chronic disease colleagues. So shifting oncology sort of paradigm from an acute care model to a chronic disease model. Diabetes education, management, cardiac rehabilitation are examples. Ultimately, it's patients and their families who shoulder the responsibility for adopting the necessary self-management behaviors to reduce the acute and chronic physical and psychological effects of cancer while dealing with multiple transitions and navigating an increasingly complex health and cancer care system. And the everyday work of life doesn't stop with cancer, so we need to design our healthcare system to better support those families. Thank you.